Welcome to our group's presentation, Critical Appraisal Prospective Cohort Study. Our patient is Mr. Tan Wei Ming. He is a 64-year-old male living in Toronto with hypertension, type 2 diabetes, and an overweight BMI. Mr. Ming presents several pre-existing factors that put him at significantly higher risk for cardiovascular disease. Mr. Ming is experiencing new onset left calf tightness and aching 36 hours after a 15-hour flight returning to Toronto. With no chest pain, dyspnea, fever, or recent trauma, he attributes this to travel-related factors such as prolonged immobility, limited hydration, and not wearing compression stockings. Mr. Ming is concerned about his risk for venous thrombosis and is seeking guidance on preventative strategies for future long-haul travel. Article description. Addressing the inconsistencies of prior retrospective and case control research, Schwartz et al. Conducted a prospective controlled cohort study to investigate the association between long-haul air travel and venous thromboembolism. This design met a World Health Organization mandate for higher quality evidence regarding flight-related VTE risk, particularly for predisposed individuals. The study compared 964 passengers on flights exceeding 8 hours with 1,213 non-traveling controls. To ensure the detection of new onset events, participants underwent compression ultrasonography, both pre- and post-exposure. Anyone using anticoagulants or compression stockings was excluded to prevent confounding. The primary outcome focused on isolated calf muscle venous thrombosis, hypothesized as a precursor to deep vein thrombosis, while secondary outcomes included DVT, pulmonary embolism, and mortality. To mitigate detection, the researchers utilized a blinded assessment protocol where ultrasound examiners were unaware of the participants' exposure status. By following subjects for 4 weeks post-travel, the study established a temporal sequence to provide strong evidence that long-haul travel significantly increases VTE incidence compared to non-traveling populations. Critical appraisal questions. Section A. Are the results of the study valid? Question 1. Did the study address a clearly focused issue? Our team answered yes. The study addressed whether long-haul flights of 8 hours or more increase the risk of venous thrombosis among airline passengers. The research framework clearly defined its population exposure outcome. The population comprised of adults undergoing long-distance air travel and a non-traveling control group. The exposure was defined as prolonged flight duration, while outcomes included venous thrombotic events, specifically isolated calf muscle venous thrombosis and deep vein thrombosis, as well as severe complications such as pulmonary embolism and mortality. All events were objectively confirmed via compression ultrasonography. A precisely focused research question is important for cohort studies, ensuring that data collection directly aligns with the investigation's primary goals. This clarity allows healthcare professionals to accurately interpret findings and determine their clinical relevance for specific populations. In this instance, the study's structured approach provides actionable data for frequent long-term travelers and clinicians concerned with the prevention of thrombotic complications. Was the cohort recruited in an acceptable way? Our team answered, can't tell. The cohort was recruited through travel agencies, newspapers, radio, television. However, this recruitment method may introduce selection bias because volunteers often do not reflect the diversity of a general population. Specifically, participants with a personal or family history of thrombosis may have been more motivated to join. Excluding individuals using anticoagulants or compression stockings limits representation even further. Consequently, it is difficult to determine if this cohort faithfully models all long-haul travelers, since selection bias can restrict the universality of observational findings. Question 3. Was the exposure accurately measured to minimize bias? We thought yes. The study defined exposure using a clear, non-subjective threshold. By collecting specific data on flight duration and travel conditions, the researchers ensured that participants were classified based on quantifiable travel metrics rather than self reported or vague definitions of long haul travel, quote unquote. To detect venous thrombosis, all participants underwent lower limb compression ultrasound before the flight and upon return. Ultrasonography is a validated gold standard diagnostic tool with high sensitivity and specificity for detecting proximal deep vein thrombosis. Using a high precision clinical tool ensures that the measurements reflect the physiology state being studied at that time. All subjects, regardless of their group, were assessed by trained physicians who were blinded to participants' group assignments, using the same diagnostic procedures. This uniformity ensures that any findings are due to the exposure itself rather than differences in how groups were monitored, effectively reducing the risk of misclassification bias. Question 4. Was the outcome accurately measured to minimize bias? We said yes. The outcome measurement helped minimize bias since the researchers relied on objective medical tests to determine the presence of deep vein thrombosis. An ultrasound test was performed as a validating diagnostic tool to detect thrombus by identifying non-compressibility in the veins. This objective approach decreases potential errors when patients report symptoms. The study also examined participants in a standardized manner, which enhances accuracy. Bias was further reduced because the sonographers were masked to the participants' group assignment, ensuring the identification of new incidents or incident events was not influenced by knowledge of flight exposure. In general, the method of measuring was suitable and competent. Have the authors identified any important confounding factors? We said yes. The data gathered in the study was abundant regarding both inherited and acquired risk factors for thrombosis. Schwartz et al. Identified these key confounding factors. Acquired: age, BMI, hormone treatment, previous DVT, PE, immobilization, and active cancer, as well as inherited factors. Screenings were done here for thrombophilia markers, included factor V Linden or factor 5 Linden, prothrombin mutations, and family history of DVT. This thorough evidence makes the study more effective in explaining confounding variables. Have they taken account of the confounding factors in the design and or analysis? We said we cannot tell. While the study compared risk statistics across groups, the discussion relied on an unadjusted risk ratio rather than multivariable adjusted estimates. Despite most similar baseline characteristics, imbalances in sex distribution and the prevalence of varicose veins suggested that the residual confounding may persist. The authors acknowledged that while a randomized design could have minimized these imbalances, it was ethically and practically unfeasible. Consequently, the lack of comprehensive multivariable adjustment means the observed associations should be interpreted with caution. Question 6A. Was the follow-up of subjects complete enough? Our group decided yes. The participants were subject to routine diagnostic tools and physical examinations to identify suspected venous thrombosis. A 4-week follow-up was completed for all individuals in both groups, and the results were documented for each participant. According to Gayat et al., this exhaustive approach is important for study validity, as it minimizes the possibility of missing subjects, which could otherwise skew results significantly. 6B. Was the follow-up of subjects long enough? We said yes. The 4-week follow-up period was sufficient because venous thrombosis related to air travel typically manifests within days or weeks of travel. According to Gayat et al., a follow-up is considered long enough when it covers the period during which the expected clinical events are likely to occur, ensuring all travel-associated outcomes were captured.
Section B, what are the results?
What are the results of the study? The study found that venous thrombotic events occurred more frequently in long-haul passengers compared to non-traveling controls. Venous thrombosis was identified in 27 of 964 passengers, 2.8%, and 12 of 1,213 controls, 1%, with a relative risk of 2.83, 95% confidence interval, 1.46 to 5.49, indicating that long-haul air travel is associated with approximately 2.8 times higher risk of thrombosis. Isolated calf muscle venous thrombosis, ICM-VT, was the most common event, occurring in 20 passengers, 2.1%, and 10 controls, 0.8%, with an RR of 2.52, 95% confidence interval, 1.20 to 5.26, suggesting that air travel approximately doubles the risk of early stage thrombosis. Deep vein thrombosis was less frequent, but showed a higher relative risk of 4.40. Although this estimate is based on a small number of cases, one pulmonary embolism was reported. Overall, the absolute risk remained low, and the 4-week follow-up revealed no additional thromboembolic events, suggesting limited clinical impact despite the increase of relative risk. Question 8. How precise are the results? The precision of the results is assessed using confidence intervals. For overall venous thrombosis, the confidence interval was 1.46 to 5.49. And since it does not cross 1, it indicates a statistically significant association. However, the interval is relatively wide, suggesting that the true risk could range from a moderate to substantially higher increase, reflecting reduced precision. For ICM-VT, the confidence interval 1.2 to 5.26 also indicates statistical significance, but remains wide, again suggesting some uncertainty in the exact magnitude of risk. For deep vein thrombosis, the confidence interval 1.04 to 18.62 is very wide, indicating low precision and greater uncertainty due to the small number of cases. Overall, although the findings are statistically significant, the wide confidence intervals reduce confidence in the precision of the estimates. Question 9. Do you believe the results?
Yes.
The results are reasonably credible, but they should be interpreted with caution. The study used a prospective cohort design, allowing for assessment before and after exposure, which strengthens temporal relationship. The use of compression ultrasonography, a non-traveling control group, and blind assessment further supports the validity of the findings. However, there are limitations. The results are unadjusted, meaning the potential confounding factors such as age, BMI, and other risk factors may be influenced by the findings. Notably, most participants who developed thrombosis had at least one pre-existing risk factor, which may limit the generalizability of the results. Additionally, the wide confidence intervals and low number of events reduce the precision and reliability of the estimates. Furthermore, no additional events were observed during the 4-week follow-up, suggesting that the overall clinical risk may be low. While the study demonstrates an association between long-haul air travel and venous thrombosis, the findings should be interpreted cautiously due to potential confounded and limited precision.
Section C, will the results help locally?
Question 10. Can the results be applied to the local population?
Our group said yes, with minor limitations.
While Schwartz and colleagues focused on German long-haul airline passengers, the findings remained highly relevant to Canada. Although original study population reflects a specific European geographic setting, venous thromboembolism is a significant local concern, with a Canadian incidence rate of 1.22 per 1,000 persons a year. Since long-distance international flight is a common exposure for Canadians, the biological mechanisms identified in the Schwartz study are globally applicable and biologically plausible. A cohort study design was ethically appropriate here, as the researchers cannot randomize subjects into potentially harmful exposures. Canadian data, specifically from Quebec, supports a link in VTE cases increasing with age and diabetes in a manner consistent with the risk factors associated by Schwartz. Despite clinical relevance, the study lacks transparency regarding cost considerations. It did not report the financial implications of screening, prevention, and diagnostic strategies. This omission makes it difficult to quantify the economic burden and the cost effectiveness of implementing specific local prevention programs based solely on these findings. Question 11. Do the results of this study fit with other available evidence?
Our group said yes.
The results of the short study are supported by other available evidence examining travel-related VTE. For example, Cupers et al. Conducted a systematic review of travel-related thrombosis and reported that long-distance travel is associated with approximately 2 to 3-fold increase in the risk of VTE, particularly for journeys exceeding 8 hours. The review also identified prolonged immobility during travel and the presence of underlying risk factors such as older age and elevated BMI as important contributors to thrombosis risk. Because these findings are consistent with those reported in the Schwartz cohort study, the results appear to align with the broader body of evidence on travel-associated venous thrombosis.
Question 12 asks, what are the implications of this study for practice? Yes, we believe the study provides meaningful implications for clinical practice in patients like Mr. Adrian Tan Wei Ming. For example, clinical awareness, risk assessment, and patient counseling related to travel-associated venous thrombosis. As demonstrated in this table, the Schwartz cohort study aligns well with Mr. Tan's clinical profile and travel exposure, and its relevance extends beyond comparison by helping to inform clinical decision-making in similar cases. From a practice perspective, while a single prospective cohort study cannot overhaul health policy, this research provides evidence linking prolonged air travel to venous thrombosis. Notably, using a cohort design was a necessity. Conducting randomized control trials on harmful exposures like prolonged immobility is ethically prohibited. Therefore, observational studies remain the gold standard for assessing such risks in the general population, though they must be interpreted with caution regarding potential bias and confounding variables. For healthcare providers, these findings serve as a diagnostic tool. Clinicians should consider recent long-haul travel a contributing factor when evaluating patients with VTE symptoms, such as leg swelling or calf pain. Furthermore, the study emphasizes the need for targeted patient education, particularly for high-risk groups. The research supports universal preventative strategies like maintaining mobility and ensuring adequate hydration during flight. However, because this study did not directly evaluate more aggressive interventions such as anticoagulant therapy or compression stockings, these should be considered on an individual basis for high-risk patients. Overall, while this study provides valuable insight, it should not be used in isolation, but rather alongside other evidence and clinical judgment to support safe and informed decision-making in practice.
Now let's talk to our client. Mr. Ming, you're concerned about risk for venous thrombosis and are seeking guidance on preventative strategies for future long-haul travel. Research indicates that long-haul flights exceeding 8 hours is associated with approximately 2.8 times higher risk of developing blood clots compared to not traveling. Your risk is influenced by pre-existing conditions, including your age, hypertension, type 2 diabetes, and overweight BMI. Most individuals from a Schwartz study who developed a clot had at least one such risk factor. The calf tightness and aching you experience are common signs of early-stage thrombosis, so it's important to monitor for these symptoms following long trips. To reduce your risk during travel, it's essential you maintain mobility by performing regular seated leg exercises like ankle pumps and walking in the cabin aisle to prevent venous stasis or blood pooling. Staying well hydrated is also key for prevention. Wearing compression stockings and sleeves is a generally recommended strategy for higher risk individuals. And because travel-related clots typically manifest within days or weeks of a flight, you should continue to monitor for symptoms like leg swelling or calf pain for at least 1 month after returning. Before your next trip, please consult your healthcare provider to discuss additional interventions like temporary anticoagulants. Credits. AI statement, references. Thank you for your time.